Good afternoon, Damien and NMAC team. Thank you very much for having me today. It's an honor to join you. Um, so I'm David
Hello,
Harvey.
everyone. Sorry, go ahead. Go ahead. Introduce yourself. Yes.
I'm sorry, Damien. Did you wanna say
Yeah.
something?
No. I wanted to thank everyone for your time for joining us today. I'm really excited for this opportunity to have a conversation with you all. As we have seen an increase in STI rates in the U.S., and I am particularly interested in discussing how disparities are observed, particularly for gay men of color. And that's why we have invited a group of experts. One of them being David Harvey. David is the executive director of the National Coalition of STD Directors, and he previously has funded other organizations, founding executive director of AIDS Alliance for Children, Youth, and Families, and he currently focuses his work into bringing greater visibility among the American public and policymakers about the STD issue in the US. And I am also very happy to have Andrew Ogata and Dash Dax part of this conversation. They will be part of the community conversation where they will be presenting, they will be providing their perspective from their own context. Andrew Ogata and Dash are also part of NMAX Gay Men of Color Fellowship. And just a little bit of background on Andrew. He's a fourth generation Japanese American from Hawaii, and he works as the director of marketing and development at the Hawaii Health and Harm Reduction Center, where he oversees comprehensive communications. And also we have Dash, is the program manager at Power Atlanta, an organization specialized in finding innovative ways to increase health literacy in the community, and he has extensive experience in developing and implementing programs focused on health equity and active community engagement. So for the first part of this webinar, we are going to have David Harvey present some data, and then we will be have a discussion with all of the panelists. I want to remember the attendees that you are able to ask questions through the chat function. And Taylor, who's in the background making all of this magic happen, will read it out loud for us. And I also forgot to mention that Elizabeth Phil is also with us from NCSD, and she is going to be helping us to kind of make sense of some of the data. So you can, for the attendees, feel free to make questions that are more specific, and she will be here to support us on that. So I will pass it over to David. Thank you so much for joining us.
Thank you, Damien. It's an honor to be with all of you today, and thank you for your efforts to organize this webinar, and Taylor for your logistical support. And I am joined by Elizabeth Finley from the NCSD team, and our colleague Leo Parker could not join us today due to a death in his family, but we'll do our best to be able to answer questions and to present some information today. And I have a number of slides to go through. Before I do that, though, some quick caveats. I'm not an epidemiologist. I'm not a researcher. I'm not a doctor. In my career, have grown up in the public policy world, and I've been in leadership positions within nonprofit organizations. So I think our goal today is to largely have a lay-friendly, um, open discussion of the current issues around disparities of sexually transmitted infections among the GBMSM community, or otherwise referred to gay men of color. We have some enormous disparities, and we are challenged in the United States today to get on top of these infections and to deal with the intersections between STIs and HIV. So, without further ado, I am going to go through the slides. There are quite a few. Some I will spend more time on than others. And then we'll save time for a discussion. and other presenters. So a little bit about NCSD. We are a national association that represents state and city and U.S. territorial health departments. These are the entities that receive STI prevention funding through the Division of STD Prevention at CDC. And we, similar to MMAC, similar to colleague organizations like NASTAD, we serve our membership. And we do a variety of training and technical assistance programs, public policy work, and media relations. Why is my slide not advancing? All right. We have about 5,600 members of NCSD. It's the state STI directors, as I just reviewed, but we also have other membership categories, and it includes about 1,400 STI in clinics that are embedded in larger organizations or standalone STI clinics or part of HIV service organizations. And then we work with an element of the public health workforce called DIS, Disease Intervention Specialists. These are folks on the ground doing outbreak response, knocking on doors, navigating people through the healthcare system. And as I've already said, we do a lot of public policy work, media, training, and building the capacity of our members. The DIS workforce is where we have seen a lot of development in the last couple of years. And by design, this is a very diverse work group. The DIS workforce is hired from the communities they serve. You can see here some of the statistics that show various demographic information on DIS and their backgrounds. An essential component of this workforce is to come from the communities they are trying to serve, to build trust, build relationships, and get people the services that they need. We are engaged in a very broad range of issues. When we are talking about sexually transmitted infections, scientists will tell you that there are probably upwards of around 40 to 45 sexually transmitted infections. In the United States today, we only surveil 4 of them: HIV, syphilis, gonorrhea, and chlamydia. But there's other STIs that we do work on. And of course, each one of these things has their own profile, their own causes of disease, and differing symptoms. But not being a clinician, I'm not going to go on about that. That is for sure. The scope of the STI epidemic in America today, these are the numbers. It is pretty shocking. We are facing a very large syphilis epidemic in America that's now translated into babies being born with syphilis. You can see here on this slide that there has been a 183% increase since 2018. We are also facing potential drug-resistant gonorrhea in this country that has emerged in other parts of the world. So there are some urgent needs around development of new treatments and diagnostics. Taking a look at the number of babies being born with syphilis is a shocking number. We call it a sentinel event in the public health world, and it means that the system is failing. And it's a very bad sign and points to the fact that we are missing women. Women are falling through the cracks, not getting prenatal care, not getting diagnosed, and not getting access to Bisolin, the antibiotic that can prevent syphilis in newborns. Okay, slide. Why won't you advance? Okay. Uh, when it comes to analyzing race and ethnicity data and disparities in STIs, we are a little bit limited by the data. But this is a somewhat complex slide, and I have a feeling this may have advanced by mistake. No, here we go. Bear with me, folks. Okay. So this is what some of the data looks like when you're looking at race and ethnicity in the context of gonorrhea. And what this colorful chart shows you is the actual disproportionate numbers and rates among communities of color. Here is chlamydia. Same thing. You can see there are enormous disparities. These disparities track what we also know about disparities in HIV. Communities of color in the South, in parts of the country that have not adequate access to health care, not Medicaid expansion states, low resources. All of this intersects. And here, of course, is a slide on syphilis, which is a similar pattern of disparities. Uh, Here's a slide that shows disparities specifically by sexual orientation. And again, this is complex. This comes out of a epidemiological study called SUN, which is funded out of CDC. It's an enhanced surveillance program that looks at STI clinic patients by age, group, sex, and sex of sex partners. And you can see demonstrated in the graphs some of the disparities among men who have sex with men and men who have sex with women only. And similar, a chart that similarly shows some of the disparities in syphilis. This is primary and secondary syphilises, reported cases by sex, sex of sex partners, and race, Hispanic ethnicity. This is the intersection of syphilis and people with HIV. This is another disproportionate impact. People with HIV have higher cases of syphilis. And this looks at age groups. Sorry, I'm having a little trouble with advancing these slides for some reason. NPOX is back in the news. I don't think I have to tell you that. What is happening right now is that we're monitoring emerging cases in the US. There has been a slight uptick in cases identified around the country. People are very worried about what is referred to as clade 1, which is a more virulent, more deadly version of mpox than what we saw 2 years ago. Cases have emerged in Africa and some in Europe, To our knowledge, as of this date, there have been no diagnosed cases of clade 1 mpox in the US, but we do expect this to arrive within the country. And is the system ready? Well, we can look at a few data elements, and we know that mpox vaccination rates are not what they need to be. So the focus really needs to be on encouraging people to get the vaccine, Genios, made by Bavarian Nordic. The other major issue we have been dealing with in the United States is a shortage of Bicillin. Bicillin is the antibiotic that treats syphilis and is made by one country with a key ingredient that is manufactured in China. And this is not the first time there has been a shortage of this drug. This shortage happened a couple of years ago as well. So we've had repeated shortages. And what it has meant is that there has been rationing of access to this drug with a priority on pregnant people and everyone else in certain jurisdictions has been prescribed doxycycline, which is a less effective treatment option because you have to take pills for 30 days in a row to ensure that you clear the infection. There's a lot of debate among clinicians around these differing treatments. There is no question that Bicillin is the best treatment for syphilis. The shortage is now easing in the United States as the supply is increased. We've done a lot of work at analyzing why this shortage happened and what needs to happen to kind of permanently fix this situation. This drug shortage is on top of many other drugs that are on a long list of shortages. The White House has been working on this. Congress is thinking about legislation. So drug shortages in America, unfortunately, is a problem. And for our sector and our field, this has very much been of concern. DoxyPEP, another big issue that I'm sure you have all heard about. New research out shows that doxycycline is remarkably effective at preventing an STI if taken within a window of time following sex. The percent efficacy rates for preventing an STI differs a little bit per STI. But overall, it remains a very effective treatment option, and it's a cheap drug, and it's a drug that has been around for a long time. Nevertheless, it costs money to implement these new types of treatments, and that is what our field is adapting to right now, getting the word out, educating people. When you talk to an average consumer around DoxyPEP, there are usually lots of questions about how to take it, when to take it, how much to take it. Elizabeth Finley, who is with us today from NCSD, has done a whole series of focus group discussions with people and have learned what some of those questions are. So we are very much in an implementation mode at this point with this new treatment option and preventative tool. And so we will see the impact of this as we go forward. This is some of the results of what we see as and what comes out of our focus group research related to DoxyPEP barriers, insurance coverage. Even though this is not an expensive drug, there is still a cost involved. People have questions about side effects, interactions with other medications, lack of insurance coverage. And you can see where some of the data results fall here on this chart in terms of what was of most concern and interest to people. NCSD has, as a committee of our board of directors, an MSM advisory committee. It includes people from health departments across the US, and they came together to write a document called Power, Pleasure, and Equity Principles for Supporting the Sexual Health of Gay, Bisexual, Queer, and Other Men Who Have Sex with Men. And we are seeking people to sign on to this document. And it was based on a series of other types of documents that are called principles, including the Denver Principles, which was an early document written by people with HIV in the early years of the epidemic. This is not unlike that in that it is centering these concepts in an overall set of principles to guide the delivery of services. In short, in America today, we have an out of control STI epidemic. CDC has one funding line specifically for STIs, and that is about $170 odd million. Compare that amount of money when we're looking at HIV appropriations or appropriations for a number of other infectious diseases. We are working very hard to catch up on appropriations and winning new resources for this field. And part of the strategy is to better leverage other federal programs. Right now, Admiral Levine, the Assistant Secretary for Health, has convened a syphilis task force with that goal in mind. So they're trying to, using existing resources, do more work with HRSA, CMS, NIH, CDC, and other components of the US Federal Department of Health and Human Services to do more around STIs. Our work at NCSD has been very much focused on winning additional resources for CDC and trying to increase the total pot of money that is available for health departments and community-based organizations to do more in this area. And those are my slides. And I'm sure there'll be lots of questions. I am going to stop sharing.
Awesome. Thank you so much, David, for that comprehensive presentation. I would like to ask Andrew and Dash to join us in the conversation. You may turn your cameras on. And also, as a reminder for the folks attending the webinar, please make sure that you ask your questions through the chat, as we want you as part of this discussion. And before we go with the questions from the audience, I wanted to bring Andrew and Dash for your thoughts, for your from your experience in your very specific context in Hawaii and in Atlanta. So I think David was able to provide us with an overview of those disparities that are observed in particularly among gay men of color in the US. But I would like to really ask you to help me and help the audience understand why are those disparities observed. So I would like to ask you, what do you think are the primary social and structural barriers that contribute to this disproportionate rates in STIs among gay men of color?
Good evening. Thank you for having me. I enjoyed the presentation. It was really good. Your organization have done a lot actually for my previous employer and as well as the one I work for now, as far as providing us with resources and condoms, David. And I'm also a member. Um, in the Black community here in Atlanta, there's a lot of male normers and misnomers and misinformed people about STDs and the causes of what STDs can actually grow into other than a burn and an itch. A lot of people suffer in silence. there's an uptick in bug chasers, people who want to get STDs, which is very sad. I think lack of insurance. There was a poll recently we conducted here in the state where it showed the drop in Louisiana versus Georgia because we have an annexed into the public health care, and paying for it is a big thing, and then treating it. Then once, if I have to go somewhere and get treated for it, how I'm going to pay for it if I don't have the finances to pay for it? So those are some of the biggest reasons that we have an uptick in STDs here in Atlanta. Let alone we have a very big culture of sex clubs and adult entertainment industries here in Atlanta. So that compounds even more into that. Moreover,
Just to jump in here for to give a different perspective from over here in Hawaii, I think that there's several different reasons that we could look at for the disparities, especially amongst that's affecting our gay men of color. I think for a really long time, the trend of thought was I'm going to take my prep, but whatever else I get, I can treat, right? But now we're seeing like these resistant strains and whatnot. And so it really needs to be a multi pronged approach that completely taking care of your sexual health. And, you know, it is prep is important and prep is should be at the forefront. But in addition to prep, we need to really enhance things like doxypep. And I know in my personal experience, when I'm talking to my partners or whatnot, Doxy is something completely new. We are exactly where we were with prep like a decade ago, and you know, it's having to really have these conversations. Um, I think another probably reason that I see is that the lack of resources. For a really long time here in Hawaii, you know, we're out in the middle of the ocean. We had very limited STI treatment and testing resources. So just recently, like organizations like HHHRC, we just really ramped up our STI testing and we're able to offer full panel testing here now. And we are an additional resource in addition with Department of Health here in Hawaii.
And I think you're both bringing really important issues. Sorry, David, I think you were going to add something.
I'm sorry, Damon. I'm just going to pipe in with 2 points because I think
Yeah.
Andrew and Dash made some very important points. And one thing I also wanted to bring to light is that research shows that if you have another STI, you are up to 8 times more likely to get HIV, which is why the national community has been focused so heavily on this word syndemics. How is it that we can create flexible funding streams so that local organizations like Andrews can get better access to funding to put together an entire sexual health set of services that meet the real needs of people? Because all of this intersects. And I am very, very grateful to the national HIV community for embracing an STI agenda. It didn't used to be this way. We worked very much in silos. And so by joining forces, it has had a major impact on trying to make more resources available. Of course, we still have a huge way to go, but we have made some progress, and we have to, of course, continue these efforts.
And thank you for bringing that up because that's something that I really wanted to touch base on. Because although this webinar is not HIV specific, we really wanted to highlight STIs but there's also, as you're mentioning, a direct connection with HIV. And from what you're saying, it seems that there are a lot of gaps in terms of policy to make that happen, to maybe turn that into practice, right? To be able to, for example, when a person is going to get HIV tested, then why not make it easier for people to get STI tested and talk about doxypep and talk about mpox so that people don't have to invest that much time because we know as people of color that we are dealing with so many things at the same time that sometimes this is a barrier. These are structural social barriers to um, for a healthier sexual life. So if you can add from your expertise in terms of policy, what is missing, or what should we be looking at as advocates?
I think Andrew and Dash should answer that first. And I'm happy to pipe in.
Any thoughts, Andrew, Dash, in terms of policy, or in terms of things that you have seen in your community from implementation or experiences from your program participants or clients? How can we really make sure that a syndemic approach is implemented?
I think just really creating as low barriers to your services as possible. We recently, like in the past maybe year and a half, have started a full service sexual health department here that does all the full panel STI testing as well as PrEP services, HIV testing, Hep C testing, and really just trying to make it as low barrier as possible. We go out into the community. We test at community-based events. We are able to do outreach testing. We'll meet people in parks or public places where we can go out and we can do testing anywhere that we can find a private bathroom where people can self-swab. We will do testing at, and so really just trying to create it as low barrier as possible, because we know our community, right? Like, they're not going to make the appointments. They're not going to want to come in. They're not going to want to follow all this huge go jump through all these hoops to just get tested for an STI. And people are having sex, and we saw that especially during the pandemic. Like, people were having lots of different sex, and all the clubs and bars were closed. So we really need to try to go to where the people are and meet them where they're at.
I had something I wanted to add that's been very good for me. During the Pride, we just had Global Black Pride here in Atlanta. So one of the things that we did, I was very proactive instead of being reactive. Along with my clinician, we gave doxyprep going into Pride. Hey, you're going to be sexually active. Here's something to help you. I practice in one of my roles here. I practice in creating programs. I practice a harm reductive approach versus a clinician's approach, because I'm not a clinician. Let me be clear about that. I believe in meeting people where they are instead of taking the clinician's approach. Oh, where I want you to wear condoms. I want you to get tested. I want you to be on PrEP. But sometimes when targeting specific groups of people, that may be like throwing paint on the wall. That may be fall on deaf ears. So my approach is, how can I help you be healthier? So if I can get you to take this doxy prep post instead of having you come in my office the Monday after the event, I've saw less patients. I've saw less people saying, hey, I'm burning. Hey, I'm having some sensations in that area I don't normally have. And I tried talking to other clinics and other practitioners in the area. Oh, I'm not going to blow my clients up on that. That's setting a bad standard. I'm seeing less results. It's Tuesday, the year before, when we very first launched our clinic. We had a line out of the building based on the amount of people who had unprotected sex that weekend leading into Pride. And I'm of a strong thought. If we can be proactive instead of being reactive, we can possibly see lower numbers and lower transmission rates that way.
And I think I would just add, in addition to Andrew and Dash, we have learned so much from the HIV movement in the United States. It sounds a little trite to say, but community empowerment, listening to the voices of real people in real communities across this country, and having those voices elevated about what is needed in their communities to lead a sexually healthy life, is what I think we're catching up on in the STI sector, using HIV as the example, engaging with community. One of the main ways we're doing that in the STI sector is through the disease intervention specialist workforce, and through the work of folks like Andrew and Dash, who are leading community-based organizations and are the voice of real people in real communities. Because there's been such limited resources for this, because we live in a society that has a lot of stigma and shame, embedded around issues around uh, human sexuality. These are all barriers that we need to directly confront and overcome and cause a little discomfort in people by pushing the boundaries on this stuff. Um, and then last but not least, you asked Damien, what is it that, needs to happen from a systemic policy perspective? And I'll tell you very quickly, we can get into the weeds, and I'm not going to do that. But I will say this. We have a very complicated healthcare and public health system in the US. And there's factionalized, siloed funding streams by disease, by element of the workforce that makes it really hard on the heroes who work in our health departments to try to put all this together in a way that they can put out money so that organizations like Andrews and Dash's can get these resources and then without barriers provide the services that people need in the context of their real lives, whether that is a Black gay man living in Mississippi or an older straight white guy in Connecticut. I mean, you name it, these services have to respond to the real needs of real people and meet them where they're at. And we're not really doing that right now in the US. And that's why I call people who work in health departments really are heroes, because what they are doing to try to make this system work is heroic. And it's always behind the scenes. They're not visible. They're very easy for people to criticize when something goes wrong. But I'll tell you, if we didn't have these people there, we'd be even worse off than we are now.
And I completely agree to what you all or are saying about meeting people where they are. I think we're not here to shame anybody's kinks, and I encourage people to have as much as little um, sexual partners that have fun as however fun looks for you. But it's also our job to be able to talk about sexual health and how do we push to make it more accessible so that people can get tested easier, so that there are less barriers, so that we can normalize these conversations not only about HIV but also their connections with other STIs, so that we can have a holistic sexual health and really enjoy our sexual life. Before we continue, I wanted to ask Taylor, are there any questions from the audience?
We don't have any questions just yet, so if you're listening in, please go ahead and put your questions either in the chat or you will see the question function at the top. Thank you. We look forward to receiving your questions.
Thank you, Taylor. And before we continue and talking about getting tested, this is a shameless plug. NMAC is part of the CDC Let's Stop HIV Together campaign. It's a really cool campaign where you can find resources about treatment, stigma, prevention. And there you can find the services locator where you can find services around you. And it's also where you can also request HIV test at your home, so you can self-test. And Taylor is going to be putting those links in the chat so you can find more information. Okay, so I also wanted to touch base on the role that stigma plays into first talking about STIs, talking about sexual health in general. And from your experience, how the stigma really prevents for gay men of color to be able to, from our side, to engage with providers, but also from the provider side to engage with their clients. I know that sometimes these are can be conversations that can be somewhat uncomfortable for some people, but how do we overcome that barrier and really provide tools not only for community members to talk about this with providers, but also to the providers that are today with us in the audience, um, tools to for them to navigate these conversations.
That was a
Any
big
thoughts?
question. That was a big question that you laid out there. I can only answer part of that question, but part of that question starts with we're going to have more people that look like the people that they're serving. That's one of the biggest problems. I sought high and low for a gay doctor. Um, Normally, when I would go to my doctor and I would ask for certain things like prep, well, why do you need it? What do you need it for? What do you need doxy for? Are you having that much sex? And thank God I'm not going to trade my doctor for anything in the world. I live in a whole nother state, but he's still my doctor. And I wanted to add one more thing about the mpox. And I know that it's coming back. We can't paint this as a gay man's disease. I cringed every time watching that in the last when it was around the last go round. Hey, gay men are getting it. No, we are getting it. We as human beings are being impacted by this. This is not just something that's totally to men and men of gay experience. So that's one of the biggest things with STDs, STIs. People believe that only gay people get them. People believe that it's only acceptable to people who are having promiscuous sex. So that's one of the biggest narratives that we have to change in this work. Hey, you're not married. You have two sex partners, and they have three sex partners. I run it, and my organization is primarily we service all, but we're primarily focused on a marginalized community in Atlanta, which has some of the highest HIV rates in Atlanta, which is comparable to a small town. So, and I'm meeting with a lot of Black women over the age of 45, and oh, I only have one person. Or are you married and you know, you sure your partner he's monogamous? Well, no, I don't. You need to get tested. And once we go into the conversation of why you need to get tested, oh well, I don't sleep with women, I don't sleep with men. No, you need to get tested. So we have to really take the stigma off of this being a gay person's disease or issue for gay people and say this is a us situation. That's all I have.
I really just want to underscore, highlight, emphasize what Dash said about hiring from the community and having people that represent the communities you serve. I think that biggest thing that we can do to really break down that stigma. Something else, I think, although I'm not a clinician, but I think that putting the clinicians in the room with people that are doing the frontline work and doing the outreach work goes very far. We meet really regularly with our local Department of Health, and we put them in the room with all of our sexual health navigators who are out there at the community events, or the ones that are in the testing rooms with people. And we make sure that they know these are the trends that they're seeing. These are the things that people are telling us when they're coming in, because they're more comfortable talking to us, right? Because they see a familiar face, they see someone that looks like them. So we need to make sure that we're disseminating. It's our job to disseminate that information to the policymakers, to the clinicians, to the Department of Health, so that they better understand like these are the communities these that you're serving ultimately, and this is the voice.
Stigma is the enemy of public health. Anything we can do to break down stigma, whether that is hiring people from the communities we're trying to serve, engaging in explicit education campaigns that are appropriate, evidence-based, scientific, and gets people simple, accurate information, and then engaging and talking with people is the way that we start to make inroads. We proved this time and time again in HIV and in disabilities and in the breast cancer movement. I mean, there's lots of models and examples to use. These are the same tools we need to do when it comes to people's sexual health. I think those building blocks, just talking very directly about these issues, meeting people where they are at, and trying to give simple, accurate information goes a long way for breaking down barriers. And then from there, we have to once and for all secure and get the resources that organizations need to serve their communities. And it is just not acceptable that in one of the wealthiest nations on this earth, we're not the only one, but we are a wealthy nation, to see the disparities and in the statistics that I was presenting earlier is not acceptable. There are ways to confront these barriers, and we got to summon the will to do it.
And you're all bringing a really important point about representation and representation in the field force, in between doctors. But I would also like to bring that a little bit further in terms of representation where decisions are made. Um, Instead of informing policymakers, which I think it's great, why do policymakers don't look like us, right? And how do we make sure that policymakers or those that that really have access to making decisions over our sexual lives also represent the communities that are disproportionately impacted, and I think that's key. And I wanted to, before we close out, I really wanted to have a conversation about mpox, which we have seen um, that it has been identified by the World Health Organization as of international concern. And we know that there's a lot of stigma around it. And I really wanted to ask you, how do we make sure that people get vaccinated? And I think you may have given a couple of possible answers, thinking about representation and thinking about people that in marketing campaigns really look like us, so that it's a message that really resonates. So it also, as a I wanted to reference some of the resources that NCSD has done, and they are in the chat. You can find their MPOX resources and DoxyPep resources, because I feel like they have really nailed down, representation in their in their marketing campaign. So I really would like to hear from you all. What can we do to increase awareness around DoxyPep to get people vaccinated for MPOX? Any thoughts?
Storytelling again by people who look like the people who we intend to serve. Last session we had when we did the LinkedIn session, and we were talking about stock photos. I know we breezed past it, but even when you're selecting the material to put out in the community, I don't want to say marketing material, because who wants to say we're marketing Mpox or whatnot? But when you're putting the material out, the, the photos and the access to the photos we have don't look like the people we intend to serve. So that's one of the biggest things that I'm putting together a campaign surrounding Mpox, and everything that's inside this campaign won't reflect in any way of the people that I'm intending to serve, and that sometimes can be a problem. Um, Messaging, I think we need to involve some people who were impacted last year with this about this. Um, let them testimonies. It's kind of like growing up, we would watch the people in South Africa who needed the $1.99 for the day of the animals. And I hate to point this to that. We would see the animals that were mistreated. It jerks your heart. But unfortunately, people who've been impacted by this are going to have to be the people that pretty much go out and say something.
Oh, I think we lost
I
that.
want to point out one major thing. We saw the response to Mpox the last go around. My God, we could go on and on and on about that. And Damon, thank you for posting the resources that we worked hard to develop at NCSD with practically no money. We just did it, and that's what it takes. And that's the point that I want to make. We brought MPOX under control 2 years ago because the community itself changed our behaviors and reduced the risks associated with MPOX transmission. Vaccine uptake has been really low, but it was getting the word out and educating people that led to behavior change. And it was behavior change that brought, the numbers down, not just vaccines. And, that is really powerful. So tapping into the energies of our communities who are most impacted, is what has to happen. But last go around, we had Dimitri in the White House, we had people yelling in the streets and demanding action. And unfortunately, in Washington, D.C., the squeaky wheel gets the money. It is a daily dogfight, which people don't like to really admit, but we have to fight for everything that our communities deserve to have. And we saw that play out with MPOX. We saw people having really uncomfortable conversations and making policymakers uncomfortable and arguing with each other. A lot of people don't like that. They really don't like it. But that is the only way, I think, to move communities and people forward. Constructive, healthy debates that don't mean you have to disrespect each other, but that you will present alternative views. If we hold those views in respect, it pushes ideas and momentum forward to take action. And we've seen it so many times, and we have to do it again.
I think with the ultimate end goal of getting vaccinations into people, I think just getting really creative with what our vaccinations look like. I think here we did a vaccine oasis at our Pride event for the past couple of years where people were able to do not only Mpox, but Hep B, influenza, and offer a whole array of different vaccine options for people. We were able to partner with local businesses and nightclubs, bars. We were able to do vaccine events outside of them as well. Just really getting creative and where we're reaching out to people where you wouldn't normally expect to get these types of services. You get dressed up and get ready for going on a night out. We know that it can be skin to skin contact with Mpox, with if someone has a presenting rash, and where else do you see that but skin to skin? But nightclubs, people are sweating and rubbing up on each other. Like, we thought that would be a perfect opportunity for us to partner with them and be outside and be on your way in, come in and come out and get your vaccination. So really just trying to get creative as to reach a population that's not coming into the office for regular STI testing, not coming in for regular HIV testing. So really just trying to be creative as possible.
Yeah, and I think that kind of summarizes the conversation that we've had today in terms of what you're saying about connecting Mpox vaccination with influenza, or as we were discussing, HIV with other STIs, and essentially holistic care. So I wanted to thank you all for your expertise, for your time, and I hope that for the audience, we were able to provide you some solutions or things that you might be looking at to not only address STIs, but also HIV and also address stigma. So I really wanted to thank you all again for your time.
Damien, thank you and NMAC. This was the start of an important conversation. This is a tough set of issues to tackle in one webinar. I know I feel completely inadequate going through the slides that I did with some of the logistical issues, but there's just so much ground to cover. These are really important issues to try to tackle. So I appreciate your efforts. Thank you.
Thank you. Thank you all so, so much.
Thank you for
Thank you,
having
guys,
me.
and thank you, Andrew.
Thank
Thank
you,
you.
Damien.
Thank you. Bye bye. Bye, everyone.
Bye bye.